Good afternoon, everyone. My name is Brian McHugh. I'm a neurosurgeon, and this is called the Good Samaritan University Virtual Classes. My practice focuses on spine surgery, and specifically scoliosis surgery, complex spine surgery, and minimally invasive surgery. I wanted to talk to you today, just in general, about back pain and give an update. Some of the research we've been doing in and around the scoliosis patients is now extrapolatable to the general population with back pain, which has been a tough issue over the past several decades to actually get a handle on treating effectively. So my goal with this talk is to review some of what goes into everyday back pain and then give a bit of a review on how what we've learned from our scoliosis patients can be used in the setting of everyday back pain. When we deal with back pain generally, it's a multifactorial issue. Most of the cases are soft tissue based. We might call it myofascial. You tear a muscle or a ligament or a tendon. It hurts, it can be severe, it might even put you in the emergency room, but it tends to be short-lived or self-limited. Some anti-inflammatory medications, exercise-based physical therapy, and in a short period of time, you're back to living your life. Other types of back pain have more ominous underpinnings from a pathology standpoint. You can have infections, fractures, pinched nerves, arthritis, even some tumors will go to the spine. When we first see a patient with back pain, that's what we're screening for, so-called red flags. Anything that jumps off the page in terms of your history or what you've been complaining about for the past several months to figure out if we have a high clinical suspicion that there's something like a red flag underpinning the issue. If it's more routine or bread and butter type back pain, the first steps are to get some basic imaging, get the pain under control with some almost over-the-counter type medications, and get you moving with physical therapy. We say motion is lotion. When we deal with the typical degenerative wear and tear type back pain that's most common, that usually happens in the neck and the lower back. And it's due to just kind of everyday life, using your body on a daily basis, bearing your weight. Those joints and cartilage tend to burn out. That typically kicks in around the 40s and 50s, and it's going to be a uniform process for all of us as we age. Unfortunately, some folks will go on to have arthritis in a way that causes more clinical symptoms than for the average person who doesn't have an issue. We call that stable ankylosis, or a stable stiffening and arthritic process of the spine, which is a normal part of aging. Unfavorable issues that can develop, like stenosis or tightness in the back where the nerves get pinched, spondylolisthesis where the bones actually slip back and forth, or any type of deformity that can take place, create a higher pain profile and ultimately may need to be treated with surgery. These are just some pictures that kind of show a stably arthritic back on the left there. The report you might get from a radiologist describing that image would still sound ominous with degenerative discs and facet arthritis and bone spurs, but the patient with that MRI can be functioning just fine. When you compare that to some of the pictures on the right, we're showing pinching of nerves, slipping and sliding of bones, and scoliosis. Those are known pain generators. They don't tend to improve with simple pain management techniques and exercise-based physical therapy, and you may need to be seen by someone like myself to think about potential surgery. Now, treating patients with these issues has always been challenging, and one of the latest breakthroughs we've discovered is learning more about what's normal in terms of the alignment in your spine. These pictures kind of focus on that curved shape to the spine. In the neck, at the top of these skeleton diagrams, There's usually a reversed C shape that we call a lordosis. As you get into the middle of the diagram, there's a C shape forward facing that we call a kyphosis. And in the lower part, or the lower back lumbar region, again, that reverse C shape, which we call lordosis. We've measured all of that to figure out what's normal and what's abnormal. One of the kind of striking studies came from our scoliosis patients, as I've mentioned, because there was a big study published in 2003 that really was following folks who had scoliosis as a child and then developed on into adulthood having never had it treated. The concern with them was that their scoliosis would worsen and ultimately affect their heart and lungs. We wanted to learn whether or not that was true, and the study, which ultimately was, as I mentioned, published in 2003, found that didn't happen at an appreciable rate, and ultimately those patients had no more back pain than someone in their age range without scoliosis. Unfortunately, that was generalized to mean scoliosis in general wasn't painful. But as a provider on the treatment side, we knew that we saw plenty of patients with very painful scoliosis. We also knew we weren't doing a great job treating it from a surgical standpoint. Half the patients would still have back pain after surgery, whereas the other half would be life altered and doing much better. We didn't know why. So the initial steps were to essentially look at our patients and say, let's look at their x-rays, let's look at the images we've taken, catalog every parameter we can in terms of where the bones are located, the size of the curves, measure everything on the x-ray that we can measure, and compare the two populations of patients. The patient population who after surgery is much improved and has little to no pain, and the patient population who after surgery is still in pain and wasn't helped by the intervention, and see if we can figure out which measurements are critical to success. We did that a couple different times, and one of the striking findings was anytime you're outside of what we call the cone of economy, that's that little picture in the bottom with the gentleman standing. You can stand up straight with military posture for hours. I do it in surgery every week, sometimes for 10, 12 hours a day. Your feet hurt, your knees might ache, but overall you're doing fine. And you can stand within a small cone without much effort. But once you're leaning or bending outside that small cone, all of a sudden you have to engage a number of different muscle groups not to fall over. Those muscles become fatigued and painful over time when you're chronically in a suboptimal position. The picture of our friend, the skeleton over there on the right, is an example of someone whose degenerative arthritic back has lost that normal curvature we were looking at earlier and pitched our patient forward outside of his or her cone of economy. They stand in that listed position in the grocery store, in line at the bank, walking around the neighborhood, and they develop over years degenerative, chronic, refractory back pain that doesn't respond to medication, injections, physical therapy, because their skeletal structure, the nature of their arthritis, has positioned them in a way that their muscles will always be chronically overused and inflamed. We learned that when we do surgery that appropriately realigns our patients, they do much better from a quality of life standpoint. So the rest of the work, once we learned that, was to figure out exactly what the measurements we need to achieve are. One of the striking findings when we were looking into that was this picture on the far left. That's a focused picture of right around your hip. It includes your tailbone and your pelvis. Don't worry about the details. The basics of it are essentially your tailbone docks into your pelvis, really when you're born, at a certain angle. If that's a very high angle with a very steep positioning of your tailbone, you're set up almost like a quadruped. Think of a dog or a horse. the angle your spine would start from that kind of a steep tailbone, would shoot you out horizontal to the floor. In order to achieve our upright standing posture, you need an awful lot of curvature in your lower back to offset that steep angle of your tailbone. In other words, you need a high degree of lumbar lordosis to be comfortably upright. Someone with a much less angled tailbone does not require that much bend or lordosis in their lower back. So when we look at patients now in the clinic, one of the first things we check is how their tailbone docks into their pelvis. If it's very steep, we know we should expect in a healthy individual a high amount of lordosis. If we don't see that and we see a relatively straight lower spine, we're concerned that that patient may be listed forward and perhaps their back pain is generated from an alignment issue. We need to take that into consideration if they were to come to surgery for a variety of different issues. The other thing we learned is that there are various movements or postures you can adopt to offset some of these natural issues that arise as we age. So everyone's going to lose a little bit of the cartilage in between the vertebrae, those are the discs. As those dry out and degenerate as we age, happening to everyone, you lose a little bit of that curvature, and everyone's listing just a little bit forward. If you walk around looking at all different ages on the street, that's not what people look like. The reason is you can tilt your body back just a little bit and offset that degenerated spine that's pushing you forward slightly. This diagram is meant to help envision that. The little circle at the bottom of it is meant to act as your hip, and the tailbone is the triangulated area at the bottom part. The rest of the white line is meant to model your spine. In the A panel, that's someone who hasn't adjusted their posture yet. Their bones put them with the top of their spine very far forward in relation to their hip. The panel in B is someone who's posturally or using their muscles sort of pulled their upper body back into a more upright position. And C is how you might find someone walking around the street. They look upright, everything looks normal, but in reality they're using a lot of energy to be able to do that because their spine no longer has the alignment it did when they were, say, 25 years old. That's just one example of some of the postural changes you can use to accommodate for the degeneration in a spine as we age. It's known to be a pain generator, and another thing that we've taken from our scoliosis patients and now use in our everyday back pain patients. Once we had realized all of these new findings, and most of this came out in the mid to late 2000s into the 2010s, and we're actively researching it today, we did a lot of work to try and put together a formula that we could label or categorize our patients with. That's ongoing work, but very worthwhile. Hopefully someday everyone who comes in with a complaint of back pain will immediately be put into a category and will know exactly what needs to be done next based on their classification. We're not quite there yet, though. Active area of research. One of the other postural changes that we discovered is a tightening or a stiffening of the upper back. So if you look at our patient here, the left version is someone who's listed forward. Like we mentioned, they have arthritis in their back, the cartilage or discs in the lower or lumbar region have flattened, and that has left them pushed out, standing with their nose or their face in front of their toes when they're walking. They are able to, again, roll their body backward. That may not fully get them upright. The next step is to straighten out their upper back. Almost a hyper example of military posture. They take the curve or C shape out of that mid portion of their back. That keeps them very upright. They can walk quite easily in that position, but they're using a lot of energy. It's one of the reasons we realized we see a lot of patients not just with lower back pain, but back pain throughout the spine. My whole spine hurts is a common complaint. That's probably due to arthritis in the lower back, resulting in a number of postural changes that run up and down the spine. This slide is just meant to let you know that the same type of alignment issues occur in the neck as well. This is a newer field that we're going into now. The original work was done in the lower back, but we're finding similar results in the neck. And it's all related ultimately. The spine, whether it's the cervical or neck region, the mid-torso or thoracic region, or the lower lumbar region, isn't two different organs. It's all one spine that's connected. So it makes sense that what we found to be true with regards to the lumbar region of the lower back is also true in the upper cervical region or the neck. They're all connected on a given patient as well. This series of photographs is meant to illustrate how you really need to take the whole patient into account to understand what's generating the symptom. Our normal patient here on the left has excellent posture with the head perfectly positioned essentially over the tailbone and over the hip joint, which is over the knee and subsequently over the center of mass of the foot. Perfect posture, so to speak. Both of patients B and C come into the doctor's office with back pain. Typically or traditionally, the workup would focus on the lower back and be looking for pathology in the lower back or lumbar area. What we've learned from our alignment studies is you can have a patient like patient B here who has a predominant neck problem. So if you look more closely at that image, the neck is actually lacking the normal reverse C shape that it should have, or lordosis, which would push the head out in front of the center of gravity. This patient has compensated from a posture standpoint, like we talked about, by swinging their torso back, sitting into their pelvis. But that requires an awful lot of energy. It uses the lower back muscles, the gluteal muscles or butt muscles, and the hamstrings or leg muscles. So the patient comes in complaining of low back pain, buttock pain, and leg pain, when in reality they have a neck problem. Patient far over on the right there is the classic patient we've been discussing to date. When you take a look at his or her whole spine, that's an isolated back-related problem, but it's due to an alignment issue. That patient is decompensated. They're sitting as far back as they can into their pelvis, using all the postural muscles they can to get upright, but their loss of lordosis or curvature in their lumbar spine is too much to overcome, and despite that effort, they're still listed forward. Those folks tend to have pain scores in the 8, 9, and 10 out of 10 range. Understanding these spinal and pelvic alignments and getting ranges for what's normal and what's abnormal has been a major change in the way we view a typical patient with back pain over just the last 10 years, and it's had huge impacts on how we design and strategize our surgical fixes for these issues. I think a couple of examples may help highlight how these issues can come into play. Our first patient here is a 56-year-old female, 56-year-old female, who's had surgery in the past. Unfortunately, the surgery she had was done about 15 years ago, so predates what we've learned in this talk and in the community of spine surgeons about alignment. So her previous spine surgeons had done fusion procedures for disc herniations and arthritis in her lower back, and you can see the pins and screws used on the x-ray here. But they aligned her in a way that kept her lower back, where the pins and screws are, at an angle that pushes her whole torso out over her center of gravity. This is a clinical photograph of her doing the best she can to stand upright. You can see the cane in the foreground that she usually uses to walk because she needs that to support that leaning posture she requires. That's because her prior surgery left her in that position and she can't overcome it. The goal of surgery was to realign her, which is exactly what we did. Here are her postoperative x-rays on the right side showing her torso in better alignment. If you're not used to looking at x-rays on an everyday basis like we are, the patient's pictures herself, I think, speak volumes for what alignment means to someone. The picture on the left, again, is the patient grunting and using all of her muscles to get as upright as she can. We had asked her to stand as straight as she possibly could, and she was sort of pulling back on her gown to get into that position. The picture on the right is after surgery and shows her relaxed in her hospital room recovering with perfect posture. The patient on the right has very little back pain after she's recovered. The person on the left has basically been on narcotics for the past 10 or 15 years and was considered a failed back surgery by the surgical community prior to our understanding of appropriate alignment. One more example, another tragic case. This patient had gone through 10 prior surgeries, all by very accomplished surgeons, but predating what we understood about alignment. Hopefully, from what you've learned from this talk, you can see that that picture on the far right shows that she's listed quite forward. The back of her head is in the top right panel of the rectangular picture. That's a terrible posture to be stuck in, and she's another patient who's been on narcotic therapy on a daily basis for the past 10 or so years. Surgery here is not small. She needs a complete realignment and reconstruction of that region. But that's very accomplishable, and once we were able to do that, she's much more upright. The picture of her preoperatively is less striking because she's able to bend her knees and lean on the walker to keep her head over her center of gravity. But postoperatively, you'll notice she doesn't have a walker. She's comfortably upright. And even surgeries of this size leave you quite functional after you've recovered. One final example is a patient who highlights what a neck issue can do to the rest of the spine. This gentleman, unfortunately, had gone through several surgeries on his neck. The picture here on the right, I think, is more appreciable. You can make out the soft tissue of his face, jaw, and skull. You can see the metal pins and rods that were placed previously with surgery. However, his head still slowly fell forward, almost like a bowling ball on a stick would, just from gravity. His chin was ultimately tucked down to his chest. What did that mean? It meant all of his center of mass was pushed forward. Just to stand upright and have a horizontal gaze out in front of him so he could walk, he had to straighten his entire spine, use all of his gluteal and hamstring muscles to pull his torso back. Terribly uncomfortable. Only way he was made comfortable on a daily basis was with chronic opioid use, narcotic use. Ultimately, that's something that needs to be fixed surgically, which we do by realigning the spine. Here's a shot of his preoperative picture on the left and a realigned postoperative picture on the right. That patient was able to get off chronic narcotics and live a normal functional life. These principles that we've seen in practice with our scoliosis and deformity patients are now being applied to our more typical back pain patients, both in a treatment setting to strategize the appropriate surgery and say, let's make sure we do this surgery technically well and with the appropriate alignment in mind, as well as with our complex patients where perhaps one or two surgeries didn't solve the problem. Instead of jumping the gun and labeling that as a failed back surgery patient and condemning them to a life of palliative treatments, we now take into account their entire alignment of their spine and make sure we've optimized their standing posture. One final example. This is an unfortunate patient who suffers from a condition called ankylosing spondylitis. That's a rheumatologic condition, an inflammatory condition where the bones and the joints actually fuse into position. This gentleman was actually born upright and straight. Unfortunately, the nature of this pathology is to slowly kyphose or list forward to extreme degrees. Here's a picture of him in the clinic. He had a picture in his wallet from about 15 years previously where he was at a wedding with friends, upright, waving, enjoying the day. His story to me in the clinic was over the past 15 years, he'd slowly adopted this posture. Unable to even see forward, his head was fixed in a position where he was staring at the ground. Decades ago, it would have been very unclear how to appropriately treat this patient. The alignment would have been guesswork. But based on what we've learned in the past 10 years, we can figure out exactly the right way to tactically design his surgery to optimize his posture and quality of life, which is precisely what we did. Over several operations in a staged fashion, we were able to bring him to an upright posture, allow him to walk comfortably, see in front of him, and enjoy a normal life. What we've learned goes on, and it does tons of good for the patients. And being able to take what we know from extreme examples that I've shown you and adopt it to our everyday patient, I think is going to prevent some of the cases we've shown here today from ever happening in the first place. So if you're suffering from back pain and have been for a long time, make sure your doctor and your physician are taking into account your overall alignment. It's relatively new, but it's something we should all know about as we move forward, especially in the world of back pain. Thank you for your time. For more information, please visit www.good/Samaritan-hospital.org. My name again is Brian McHugh, and I'm a neurosurgeon focusing on scoliosis, complex spine surgery, and minimally invasive spine surgery.